Thank you for your introduction, and thank you for organizing committee to give me chance to share our local experience in treatment of managing challenging cases in sickle cell anemia in Prince Mohammed bin Nasser Hospital. So this is my disclosure, and I will go through short introduction about sickle cell anemia. It was taught previously by Dr. Al-Hamidi and Dr. Mohsin. So sickle cell anemia is one of the most common inherited life-threatening disorder in human. It's predominantly affect people in Africa, India, and Arab ancestry, and its variants are genetic disorder resulting from presence of mutated from hemoglobin S, and it was result from homozygous and compound heterozygous inheritance, and the disease was first prescribed by Herrick in 1910. So it's worldwide disease distribution, and in Saudi Arabia, you know that it was the common patients in eastern province and western eastern province, mainly in Jizan area and Al Hafuf. As mentioned before by Dr. Al-Hamidi, there is two types. The first, more severe phenotype, which we are facing problems here in Jizan area. Most of our patients here, they have difficult to control with conventional therapy, and was more severe phenotype, and it was called African haplotype or Penin type, and it was characterized by low hemoglobin F and high rate of complication and hospitalization, and difficult to control by conventional therapy. Most of the severe difficult patients, they need new therapies, BMT or referral for gene therapy. The other less severe phenotype, it was called Arab Indian haplotype, which was characterized by low hemoglobin F and sometimes associated with alpha thalassemia, co-inheritance, and it has lower complication and lower hospitalization despite very severe cases in same less severe phenotype. And most of the patient was controlled with conventional therapies. So managing challenging cases in sickle cell disease, it needs a multidisciplinary team, patient-centered approach, focus on prevention and aggressive management of acute complications like vaso-occlusive crisis, CNS crisis, etc. And I will present these cases which was managed in our hospital. So the first case is a 19-year-old male patient. He is known case of sickle cell anemia. This patient, he has a history of recurrent vaso-occlusive crisis, recurrent acute chest syndrome, and recurrent lower limb deep venous thrombosis, diagnosed 2 years back. But the patient, he is not compliant to his anticoagulation, so he has a recurrence. Also, he has gallbladder stone. He denied any history of CNS crisis or periapism, and he has no surgical operation before. Sadly, the patient has no siblings, and both parents were dead. The patient has good performance, and he started to be compliant on hydroxyurea for the last few months. This is a CT in the first acute chest syndrome 2 years back or 3 years back, and at that time the patient was treated with antibiotic automated exchange transfusion with no ICU admission. But this time he came to our hospital in March, in 30th of March, from peripheral hospital with a history of a fever, shortness of breath, chest pain, cough, and admitted to ICU there as his oxygen demand increased. He has good vital signs there, only he has fever, normotensive or borderline blood pressure, and he has tachypnea and tachycardia, but he's requiring around 10-liter high flow nasal cannula, and he has bilateral crepitation on chest examination. He has leukocytosis, mainly neutrophilia. His hemoglobin is 8.9, and his MCV around 68. This questioning that he is not compliant to hydroxyurea. His platelet was normal, but he has mild hyperbilirubinemia with normal renal function test and INR, mildly elevated LDH, and he has sinus tachycardia. X-ray shows that he has bilateral infiltration, and echo study it was normal. The patient was started on antibiotic in peripheral hospital with tazocine, vancomycin, azithromycin, and prophylactic enoxaparin plus folic acid, calcium carbonate, hydroxyurea, and vitamin D. So the patient admitted to the ICU as a case of acute chest syndrome need non-invasive ventilation, and the CT chest angiography because of tachycardia, tachypnea. We did for him CT chest angiography. There is no evidence of pulmonary embolism, but he has bilateral consolidation, indicates that he has acute chest syndrome. We prepare the patient for automated. We take consent from the family and we continue antibiotic. This is the CT, shows that he has massive diffuse bilateral consolidation in the CT chest. On the next day, the patient, he was on maximum non-invasive ventilation and he's still desatting and he's still distressed with hypoxemia. So decided by ICU for intubation, and the patient intubated due to hypoxemic respiratory failure, and he's acidotic by blood sampling for blood gas. And at the same day, the patient was started on full automated exchange transfusion by 8 unit, and the called ECMO team called at that day. And early morning the next day, the patient was cannulated with ECMO, extracorporeal membrane oxygenation. Despite that, he is not on inotropic support and his MAP around 83, but he started to have multi-organ failure in favor of, he has hyperbilirubin increasing to 189, mainly direct. His creatinine also increased from 62 to 138, and he has good urine output. His abdomen ultrasound shows that he has mild hepatomegaly with one stone around 8 mm and small sludge. Bronchoscopy done at the same time, at the same day. Chest X-ray also follow up. It showed bilateral infiltration. After few days in this week, still the patient, he is febrile, but his leukocyte count was improved. Despite that, he have mild thrombocytopenia, but improved at the end of this week. Creatinine is starting to going up. He did not improve. All culture was negative, so antibiotic was managed by ID and start changes from tazocine to imipenem, vancomycin, azithromycin, and given one shot of amikacin. A few days later, the patient improved on antibiotic, and after full automatic exchange transfusion, his hemoglobin less at that time less than 30%. So the patient decannulated after 7 days of ECMO, and he was extubated around 10 days after admission to the ICU. We start him on incentive spirometry for chest physiotherapy, and we continue antibiotic for 2 weeks. This is a CT after 2 weeks, as there is clear improvement and resolution of the previous consolidation. The patient was shifted to the ward and started on oral care, limb and chest physiotherapy, nutritional support, and wound care, as he has developed bed sore third degree in sacral area while he was admitted in ICU. The patient after that, he improved and discharged home, and future plan, as he has no sibling, and sadly he has where his parent was dead, so we refer him for haploidentical stem cell transplant versus gene therapy. So this is the New England Journal of Medicine, which shows that the most common cause of death in sickle cell anemia is acute chest syndrome and hospitalization among patients with sickle cell disease. The second case is sickle cell anemia with acute chest syndrome, pulmonary embolism, and intracerebral hemorrhage. This is a 39-year-old female patient. She is no case of sickle cell anemia. This patient, she has a history of acute chest syndrome previously, received blood exchange transfusion at that time, a few years back, and she has AVN, of the hip that was has left hip replacement 20 years back, and she has also history of pregnancy-related deep venous thrombosis of the left lower limb 3 years back. As a patient currently, she is on contraceptive implant for the last 3 years, and she is not compliant to hydroxyurea, according to her, because of supply. So this patient, she denied any history of CNS crisis and no history of bleeding disorder before. And she was also referred to us because of history of fever for 5 days in peripheral hospital, followed by chest pain, shortness of breath for 3 days, and referred to our hospital as a case of acute chest syndrome in July 2023. On arrival to our hospital, the patient was sick, and she was admitted immediately to ICU as she have tachycardia, tachypnea. She is normotensive at that time, but she is requiring oxygen. She is desatting, and she has no sign of lower limb DVT. All other examination was normal, including CNS examination. It was grossly intact. At arrival lab, she has anemia. She had mild thrombocytopenia and high LDS 3960, and she had also hyperbilirubinemia in form of total bilirubin 125 with normal creatinine. Workup showed that she have sinus tachycardia in ECG with ST elevation and T-wave inversion in lead AVR, V1, V6, V2, and V3, that suggests acute right ventricular strain and typical feature of pulmonary embolism in ECG in S1, Q3, and T3. So the patient was took to the CT chest angiography, which shows that she has multiple level of pulmonary embolism, segmental and subsegmental, and she received blood transfusion immediately with 2-unit pack RBCs. Unfortunately, the patient deteriorated, and this is the echo. Also, it was done at the same time. It showed markedly huge dilated right ventricle with impaired systolic function and increased pulmonary pressure, 41. And unfortunately, the patient, this is a CT, showed that she have bilateral involving a lower segmental and subsegmental pulmonary arteries embolism. Patient started on therapeutic enoxaparin, 1 milligram per kg subcutaneous BID, and we involve multidisciplinary team ICU, pulmonary cardiology, and hematology, as the patient unfortunately deteriorated in form of hypotension and echo finding, and they decided to start for the patient full thrombolytic therapy with actylase. So the patient thrombolized. Unfortunately, 24 hours, the patient, she developed decreased level of consciousness, GCS going down up to 10, with right side weakness, mainly upper limb. At that time, she has low platelet 78, and INR 1.3, and she has borderline blood pressure, and she's maintaining 10 liter oxygen by mask. And we did for her CT brain. It shows that she have intracerebral bleed. This 24 hours after thrombolytic therapy. The patient intubated due to low GCS and received 1-unit pack RBCs and prepared for full automated exchange transfusion, and all anticoagulation was stopped. Neurosurgery was consulted and started. No intervention at that time, as the patient kept on prophylaxis compressive stocking. This is a CT brain, shows that she have supra and infratentorial hemorrhage. We did MRI on the next day, also showed the hemorrhage. This is the MRI brain of the patient. 6 units of pack RBCs were collected and automatic exchange transfusion was done for the patient. At that time, her hemoglobin 9 and platelet only 30. Also, she received 6 unit platelet transfusion, and platelet increment up to 99. Hemoglobin S after transfusion came 7.6. We did CT brain after 4 days. After this, still there is hemorrhage, and the patient improved clinically, and they decided to be extubated after around 12 days of intubation, and she was extubated successfully. On the day of extubation, the patient, we did for her CT brain and CT chest because of she have respiratory symptom. Unfortunately, she have neo consolidation, but there is interval regression of the previously described pulmonary embolism. So the patient started on antibiotic, tazocine, vancomycin. This is a CT brain. It showed reduction in the number and size of previously hemorrhage in the brain. And again, after 2 weeks, we decide by multidisciplinary team to resume anticoagulation. At this time, the decision is to start with the half dose heparin infusion and then gradually increase and to do CT brain every 72 hours to see if there is any improvement or any new hemorrhage in the CT, and we stop all anticoagulation whenever there is sign of bleeding or new neurological symptom or imaging indicating that the worsening is of bleeding. And we decide to remove contraceptive implant by gynae and to explain to the watcher the further plan this, and we counsel the husband and the family for central line insertion and starting heparin infusion. They understood the benefit to treat and prevent further pulmonary embolism and risk for intracerebral hemorrhage. So 2 days later, CT brain it was normal and resolved intracerebral hemorrhage. So we start heparin infusion, and we did CT brain every 72 hours. And everything is okay at that time. Every 3 days we are seeing the CT brain. There is no hemorrhage. The last it was around 27 days, and it was composed no significant interval change or new developed abnormality. So the patient shifted to enoxaparin and finally to apixaban, and we refer the patient to OB/GYN for contraceptive implant removal, lymphotherapy, and incentive spirometry, as the patient discharged home safely. This is the last CT brain upon discharge, which was totally resolved intracerebral hemorrhage. And finally, around 27% of sickle cell patients, they were found to have had at least one thrombotic event during their hospitalization. So in systemic thrombolytic syndrome in sickle cell anemia with pulmonary embolism, we have to stratify the risk for our patient for thrombolytic and to review the absolute contraindication and relative contraindication for thrombolytic therapy. And multidisciplinary team involvement is always recommended for such cases. And sickle cell disease patients have vasculopathy which have increased the risk of bleeding like our patient we described. And we have to differentiate between pulmonary embolism and fat embolism. And the possibility of direct thrombolytic still is there, but she needs experienced radiology intervention team when we have high risk bleeding. And this, it has a less risk of bleeding and less hospitalization and ICU duration of admission. So from our local experience, this is a first case that we did full thrombolytic therapy, but our colleague Dr. Hafiz Anas and Dr. Muhammad Bakar before, they almost we have agreement that half dose of thrombolytic is valid and effective when we have high risk patient for bleeding. So this is case 3, sickle cell hepatopathy. I have this patient. He's a 37-year-old male patient. He's no case of sickle cell anemia, and also he has a history of recurrent vaso-occlusive crisis, acute chest syndrome, before, and also he has a history of AVN right hip, status post right hip arthroplasty, and he has also lumbar disc prolapse and secondary iron overload with history of sickle cell hepatopathy twice in the last 5 years. This patient, he was on monthly regular exchange transfusion because of all the time he has hyperbilirubinemia, and whenever he does not have exchange, his bilirubin is high. He presented to our hospital with deep jaundice all over the body and yellow discoloration of the sclera. When we saw the patient, he is hypotensive and he is maintaining his oxygen saturation, he is febrile, and we did for him lab. It shows that his hemoglobin is 9, MCV 76, that he is not compliant to hydroxyurea, and he had mild thrombocytopenia, and creatinine is high, 300 is the first time, and he has total bilirubin around 1585, that is mainly direct around 916, with high LDH. With the arranged liver enzymes, AST around 195 and ALT around 60. INR is high also. He has coagulopathy in form of INR 0.2, PTT 63 and PT 39, and hyperferritinemia in form of 3864. So ultrasound abdomen was done for this patient. It shows that he has mild hepatomegaly with gallbladder sludge, and liver MRI and MRCB was done, shows that he has feature of iron overload and no biliary stone or no CBD obstruction. So we summarize this patient that he have jaundice, hyperbilirubinemia, hepatitis B virus, antigen positive, he has transaminitis, acute kidney injury. So he received 8 units of PAC RBCs by automated exchange in ICU until his hemoglobin S reached 23%, and he was started on desferal infusion, entecavir, ursodeoxycholic acid, antibiotic, IV hydration, FFB, and last automated was done in last before 3 months, and referred for BMT, and also he is following in hepatology clinic for also possible liver transplant. So this is increment of his ferritin and total bilirubin. It was coming down after exchange transfusion up to less than 250, and his ferritin is around 3,800, and this is hemoglobin S coming down up to 23%.
2 minutes, doctor.
Okay. So for the management of liver complication in sickle cell anemia, and this is presented by Ash, and actually they divided it in acute liver disease or chronic liver disease, either related to sickling process or related to multiple blood transfusion. I will go through this and I will skip because most of them is considering regular exchange transfusion until the patient reached end-stage chronic liver disease. If he is young, so he is eligible for liver transplant plus bone marrow transplant. So in conclusion of sickle cell hepatopathy, aggressive exchange transfusion for acute or progressive intrahepatic cholestasis targeting hemoglobin less than 20%, but also to bring down total bilirubin level to baseline following by urgent stem cell transplant plus minus liver transplant. For intrahepatic cholestasis, consider regular exchange transfusion as bridging with long-term follow-up, and consider refer to mass sibling stem cell transplant. And for benign hyperbilirubinemia, even indirect hyperbilirubinemia in the absence of hemolysis, close monitoring of liver function test trend, clinical condition of the patient, and imaging of the liver, we would consider it as persistent hyperbilirubinemia, the exchange transfusion program as bridging followed by mass sibling allogenic stem cell transplant. I will go through the first case quickly. This is a 38-year-old female patient. She is known case of sickle cell anemia complicated with refractory vaso-occlusive crisis. She is on hydroxyurea 500, sometimes 1000, and sometimes of hydroxyurea because of pancytopenia. Actually, this patient, she has a history of multiple admission with recurrent pancytopenia, and she has a history of acute syndrome twice with pleural effusion and ICU admission. She denied any CNS or venous thrombosis.
1 minute, yeah, Doctor.
Okay.
Time is.
Yeah, no problem. So, because of this pancytopenia, early in 2022, they did for her bone marrow, which was negative. At that time, she was found to have COVID-19 plus dengue fever. In the last year, this patient, she was admitted 3 times because of pancytopenia due to the use of drug hydroxyurea. Actually, we are manipulating the dose. Whenever she is coming with higher dose, which she came with severe pancytopenia, we stop the drug and we commence it gradually. Her count improve until reach it normal, and whenever we increase it to 1000, again she is coming with pancytopenia. So in this year she came 3 times with pancytopenia, and she has good regular follow-up in our clinic. And all the time we are doing for her oxygen transfusion to prevent complication, and she is on antibiotic, antiviral vaccination. As this is a trend in the last year, she has 3 times pancytopenia and neutropenia and admitted as febrile neutropenia. Finally, this patient was discussed in our meeting and said, this is hyperferritinemia because of frequent blood transfusion and oxygen. We discussed her in our BMT referral meeting, and she was referred for bone marrow transplant. We tried to commence L-glutamine, but unfortunately it was not available. So she was on regular blood transfusion, inoculation, and referred to our colleague in National Guard Hospital in Riyadh. So this I have some information about hydroxyurea and sickle cell anemia. This is approved by MSH trial. This is a very multidisciplinary advanced study summary. This is a summary that it improves the rate of pain crisis, and this is also about the risk and benefit for long-term use of hydroxyurea. So our message from the last case that hydroxyurea is mandatory for all the patients, but some patients they are not tolerating or sensitive. They have sensitive bone marrow. They are not tolerating hydroxyurea, but it was essential and important to our patient. It reduced the frequency of acute cell pain, acute chest syndrome, and reduced the need for red blood cell transfusion, hospitalization, and prolonged survival. And the patient should be reminded the effectiveness of hydroxyurea depending on their adherence and daily dose. And we have to monitor well MCV, hemoglobin F, consistent with progressive laboratory response, and all the time the clinical response of treatment to hydroxyurea. It takes 0 to 6 months. And thank you.